Good afternoon. I'm here to share with you my experience with the Viva ICL. Here are my disclosures, and I'm an investigator for Star Surgical. So the ICL is probably an ideal treatment for presbyopia because many patients who come to our clinic have both refractive error and astigmatism, and if they're above 40, they want simultaneous treatment. So it does not need removal of tissue, we don't implant inlays, and it spares the eye from problems with future IOL calculations. We don't, I usually don't do clear lens exchange in our clinic. We want to preserve the residual accommodation of the patients, and there's less risk of retinal detachment if you do ICL versus a clear lens exchange, especially on a high myope. So we don't modify any of your techniques. So if you do a EVO ICL, you'll have the same surgical techniques as the presbyopia ICL. You won't need lasers. You'll have a refractive surgery center of your own without a laser. And they're reversible, removable, exchangeable, and upgradable. So presbyopia, as we know, is challenging because patients want good far and good near with no side effects, which is not true. There's always a downside, there's always a compromise. But the EVO, Vivo ICL, it preserves the cornea and the lens. So that's one of the advantages we want to keep. So the EDOF ICL is this refractive design. So it is not a multifocal ICL, but a refractive change from the center to the periphery. The center has this add power, which gives you around a diopter of near add, and it's unidirectional, so from center to outwards. It provides an additional depth of focus. So it adds a little bit of depth of focus, and it takes advantage of the reflex of the eye wherein when you do accommodate to read near, your pupil becomes smaller, so you're looking through the add part, and then when you look at distance, you're looking at the distance part, similar to your EDOF or monofocal IOL, monofocal plus IOLs now in the market. So similar principle as that. So we are on our 2-year follow-up of this study with non-toric and toric ICL, Viva ICLs. So we started about 3 years ago recruiting the patients. So it was the second study. We did our first round maybe 7, 8 years ago. And this one now, we have toric powers. So patients with high astigmatism or even moderate astigmatism can be recruited into the study. So we have 94 treated eyes. 68 of the eyes were toric, and some of the eyes, one eye was toric, one eye was non-toric, so we included them in the study. So 72 eyes now are beyond 6 months, and about maybe half are beyond a year. So the mean age of the patients in our study was about 49 years old. So in terms of refraction, so the difference between this study now and the previous study is we adjusted the nomogram to be a little more first plus in terms of targeting. So we wanted to be more planar emmetrope in the outcomes. As you can see here, the intended correction now is nearer the line where achieved and intended are near that line. And in terms of MRSE, in the beginning now, we are a little bit on the hyperopic side, about plus a half, and then it kind of regresses to the near plano. So now we see that the refraction stabilizes at near plano. The cylinders of the patients have a mean of 1.5 diopters, and 92% of the eyes were within 10 degrees of rotational stability. So in terms of visual acuity, about 80% were 20/30 or better. So this is an EDOF ICL, so it cannot give J1 near. We know that, and we explain that to the patient. So our target is about 20/25 distance, 20/25 intermediate, and about J3, J4 near, which in this cohort, we see that 80% are 20/30 or better, and 70% are 20/25 or better in distance. 81% are 2025 or better for intermediate, and about 80% are 20/30 for near. Distance-corrected near vision, 75% of them were 20/30 or better. So in terms of the focus curve, compared to a non-EDOF eye, we see that there's a wider range of the focus. I think we are adds about 1 diopter to 1.2 diopters of near add to the eye. So we tested contrast sensitivity, and we see that mesopic contrast with and without glare is very similar in terms of normal from pre-op to 6 months, and with and without glare photopic is also very similar. So we also checked for patient satisfaction, and we see that most patients were happy with their correction. So most of them didn't complain about glare halo so much, and activities, there was no limitation of activities. They were satisfied with their correction, and some of them do need some reading glass for very small print, but most of the computer patients, they felt good that they can see their laptop or their computer screens very well without glasses. So patient satisfaction definitely was better. So they were between somewhat satisfied, very satisfied to completely satisfied, about 3.6 to 4 in a scale of 5. So in terms of patient selection, what we do is we stick with 40 to 55-year-olds. Above 55-year-old, of course, the RLE option comes into play. This is a myopic group of patients with astigmatism. We follow on-label above 2.8 millimeters of anterior chamber depth and above 2,000 cells in terms of endothelial cell count. I check the DLI, or dysfunctional lens index, to make sure that everybody's above 9. So if you have an eye trace, a pentacam, look, sometimes you don't see that there's a cataract, so it's best to check because these are presbyopes. With the study, we wanted less pre-op total higher order aberration, so we were choosing patients who have less than 0.25 microns of total HOA and angle kappas of less than 0.5. The surgery, as I said, is the same with EVO ICL. So there's no difference in loading, implanting, and post-op care is the same. So I use loteprednol instead of Predforte to avoid IOP spike. Again, with presbyopia patients, when you treat, it's hard to promise everything. So we counsel the patient, same as a trifocal and same as an EDOF, that there's a little bit of trade-off. You won't get perfect far, you won't get perfect near, you have somewhere in between. But it helps you with day-to-day life, and it helps to have aggressive dry eye therapy. So having the EDOF Viva ICL with toric and non-toric function, it's a great option for presbyopic patients who are not yet ready for lens extraction. Patients have good enough satisfaction for distance and intermediate vision, and they have functional near vision, and the toric performance is similar to the spherical performance. So it allows us a presbyopic treatment that preserves the cornea and lens for future IOL innovations.